Chúng tôi xin trân trọng mời giáo sư Pitier Martinez sẽ trình bày về suy tim phân suất trong máu bảo tồn, chẩn đoán và quản lý. May I invite you to Professor Pitier Martinez for your presentation about heart failure with not reduced with persistent ejection fraction. Do you hear?
Good morning, everyone. First, thank you for your invitation to the 11th Central Congress of Cardiology in Vietnam. Yeah. For me, it's a huge pleasure to make this presentation about heart failure with preserved ejection fraction, diagnostic algorithms, and management. There are some misconceptions in heart failure with preserved ejection fraction about it is a benign condition, about it is an uncommon syndrome. Are heart failure with preserved ejection fraction and reduced ejection fraction the same condition? Is systolic function completely normal in heart failure with preserved ejection fraction? Are there effective strategies to treat it? I will try to clarify some of these points through the history. Means know that this pathology like diastolic heart failure with normal diabetes and renal dysfunction. In people over 60 years of age, the prevalence is around 5%, and it is expected to increase in the coming years. We know well that surpass heart failure with reduced ejection fraction in prevalence and in hospitalization. The identification of heart failure with preserved ejection fraction involve all levels of care, include general practitioner, internists, and cardiology. Involved endocrinology is quite important because more than 50% of patients have diabetes. Heart failure with preserved ejection fraction is a clinical syndrome with symptoms and signs caused by structural or functional cardiac abnormality and corroborated by elevated natriuretic platelet level and left ventricular ejection fraction of greater than 50%. But despite current knowledge about this syndrome, there are many undiagnosed patients. Diastole is the complex period of the cardiac cycle. Far to be passive is an active cycle with the consumption of energy and include four phases: isovolumetric relaxation, rapid ventricular filling, slow ventricular filling, late ventricular filling with the atrial contraction, and involves cellular function, mechanical function, and clinical expression. Echocardiography assessment of the left ventricular diastolic diffusion is an integral part of the routine evaluation, especially in patients with risk factor of symptoms. They are the common parameters that are evaluate in the echocardiography. And more recently, and with a great contribution, the echo spectrum tracking incorporate to the diagnosis. I want to highlight the role of the study of the left atrium. Left atrium volume index is an independent morphological predictor of death, heart failure, atrial fibrillation, and ischemic stroke. And with recent evidence, the strain of the left atrium provide valuable information in diagnosis and prognosis, even superior to the left ventricular atrial index. Other morphological parameters to evaluate the left ventricular are the left ventricular mass index and relative wall thickness. They are independent predictor of mortality, so the left ventricular geometry pattern should be reported in echocardiography study. Today, we follow the recommendation of the evaluation in the diastolic diffusion, follow the European Society of Echocardiography. The algorithm for evaluating diastolic function in patients with a normal heart failure with normal ejection fraction, and the algorithm for estimating filling pressure. But how to diagnose? The first is to carry out a meticulous clinical examination, especially in patients with risk factor, symptoms or not, and with normal ejection fraction. In this case, we must think about the diagnosis and make an exhaustive evaluation of the diastolic function, and we must go for ejection fraction. This is the last recommendation for the diagnosis of heart failure, and is proposed the following algorithm. The first step includes the participation of different specialties who must identify patients with symptoms and risk factor, support with the data provided by ECG, exercise tests, echocardiography as well NT-proBNP. The second step includes an advanced echocardiography study evaluating functional and morphological parameters in addition to time serum natriuretic peptide. These functional and morphological parameters are classified as major and minor criteria, receiving a 2 or 1 point. A new parameter in the diagnosis is having included the strain imaging in the new score. More than 5 points consider diagnosis of a fellow with preservation fraction, less than or equal to 1 point unlikely diagnosis, and 2 to 4 points indeterminate probability. The third test, in my opinion, is quite relevant and consists on performing functional tests in the group with intermediate probability. There are several ways to perform diastolic stress. The best way is the stationary bike, although you can also do it through the mat and intermediately perform an echocardiography. Diastolic stress has the diagnosis and prognosis value. In this study, for example, 45 of the diagnosis was made by functional tests in patients with normal feeling pressure at rest. And the fourth step is to establish the etiology, and here is only one to insist in the case of amyloidosis, with this more frequent than previous saw, in addition to Fabry disease, hypertrophic cardiomyopathy, among other diseases. This is the case of our consultation, main 66 years old, history of diabetes, hypertension, hyperlipemia. As you can see, ejection fraction is normal, but when we made the assessment of diastolic function, we found positive criteria of diastolic function, relation EE in 14, morphological criteria, left atrium volume index in 54, and concentric hypertrophy. When we find for NT-proBNP, find high NT-proBNP, I made the diagnosis of a fellow with preservation fraction. This is another case, female with history of hypertension, diabetes. She reported unexplained dyspnea, ejection fraction was normal, but in the assessment of diastolic function, we found functional criteria. We have morphological criteria with the left atrium volume index in 49 and concentric remodeling. In this case, we support the diagnosis with strain imaging, and that support was decreased too. And the NT-proBNP, we received more than 300 with the diagnosis of a fellow with preservation fraction. The treatment has been based on 6 mechanisms, 3 hemodynamic mechanisms, left atrial hypertension, pulmonary hypertension, and plasma volume expansion, and 3 molecular mechanisms, systemic microvascular inflammation, play important role in this pathology, cardiometabolic and functional abnormality, and cellular critique and extracellular fibrosis abnormality. And we had to take into account the specific etiology, such as amyloidosis or hypertrophic cardiomyopathy. The abnormal active relaxation and the increased passive thickness increase the left ventricular end diastolic pressure, and this is the cause of left atrium hypertension, left atrial remodeling, and left atrium dysfunction. Increased filling pressure causes pulmonary venous congestion, and this is the reason why secondary pulmonary hypertension can be found in 40 to 80% of the case, and right ventricular diffusion in 30%. When precapillary pulmonary hypertension is associated, patients may respond to vasodilator therapy, but there are some discordant results in this regard with the use of sildenafil or tadalafil, and other ongoing studies suggest the PASSION trial are waiting for more evidence into use in this drug. Plasma volume expansion has been suggested to be the main pathophysiological mechanism in obese patients, in which diuretics are indicated, and treatment with SGLT2 inhibitor show promise for its cardiometabolic benefits. The other area on the study is the inflammation. Evidence of inflammation has been found in left ventricular biopsy, circulating inflammatory marker, as well as extracardiac evidence of inflammation. And this leads to left ventricular remodeling, left ventricular dysfunction, and the development of heart failure. Many studies have been done in this group of patients, and the results are not promising. In the TOPCAT trial, for example, spironolactone was shown to reduce the primary endpoint and hospitalization. Tadalafil is being used in study in the PASSION trial. The use of beta blocker has not shown benefits in this patient, different to in patients with HFL with reduced ejection fraction. In the sacubitril valsartan in the Paramount trial, reduced NT-proBNP and improved functional class. And Paragon trial, sacubitril valsartan reduced NT-proBNP 19% versus valsartan. improve the functional class, but fail to reduce the cardiovascular death or hospitalization compared with valsartan. These are ongoing trials with SGLT2 inhibitor in diabetic patients. And recently, we received a good news for the Emperor Precept trial that showed a significant risk reduction with empagliflozin in cardiovascular death and hospitalization because of heart failure. We cannot forget the prevention, that is important, and that we must promote healthy lifestyle in our patients all the time. In conclusion, heart failure with preserved ejection fraction is a frequent clinical syndrome with multiple etiology and pathophysiological expression. We must incorporate the diagnosis algorithms into daily practice, as well as incorporated the other specialists in the diagnosis, like internal medicine, endocrinologists, and other specialists. Unlike heart failure with reduced ejection fraction, effective management of heart failure with preserved ejection fraction is lacking. And one last mention, we cannot just focus on ejection fraction, and we have to go much far that ejection fraction. This is the only way to put on the water many patients with this diagnosis. Thank you so much.
Thank you very much, and Professor Pitier Martinez for the very interesting presentation. I think this is the topic is one of the very difficult in cardiology now, because to compare with heart failure, with reduced heart failure, is more easier to understand, and we have a lot of experience. But there is some with normal left ventricular function, and after that, that is between reduced and normal, we haven't preserved heart failure. And what about the meaning, especially the pathology meaning of the heart failure with preserved ejection fraction? And I very appreciate the first slide on your presentation. That is the mixed understanding and what about for the heart failure with preserved ejection fraction. They are very interesting that now in practice it's not easy to make one diagnosis. Just before because we have only the ejection fraction through the sonography, that is the echocardiography, and after that the what is the functional test or kinetic, and for example the tissue Doppler and another one is not available or not easy to make it. And especially that's for the practice, for the doctor. They said, what about the special treatment for these heart failure with preserved ejection fraction? And some experts that no, there is no medication or something like that. The whole thing is we have to treatment actual the cause of these heart failure or a symptom of heart failure, clinical or symptom. But there is no special no drug to be shown with evidence. That is and especially the mechanism. And therefore, a lot of doctors they think that is the heart failure with preserved ejection fraction. That is the previous state of heart failure with reduced ejection fraction. Something that like this is a very interesting report, and we want to alarm and to make one alarm for the doctor. That means cardiologist, and also GP about that. And maybe we need some more study in the real world in Vietnam. What about the importance of heart failure with preserved ejection fraction? Thank you very much, Doctor. We have time to discuss and the end this session. And therefore, may I invite you and you'll move the next Next speaker. Chúng ta còn có